Welcome back to the Neurostimulation Podcast. Today I'm joined by Dr. Theodore Henderson, a trailblazing psychiatrist and neuroscientist whose work is redefining how we understand and treat brain disorders. From depression to traumatic brain injury, long COVID to chronic fatigue syndrome, Dr. Henderson has pioneered approaches that challenge the outdated chemical imbalance model. His new book, Brighter Days Ahead, offers hope grounded in neuroimaging, infrared light therapy, and ketamine. In this episode, we're going to dive into revolutionary treatments, neurobiology, and Dr. Henderson's own personal story that fuels his mission to change lives and change minds. Dr. Henderson, thanks for joining us today.
Thank you for having me, Michael.
So maybe we can start with the big picture. I was wondering, perhaps you could introduce yourself to the audience a little, tell us about your background, and then maybe help us to understand how do you see the field of psychiatry evolving away from the legacy chemical imbalance type of model?
All right. Yeah, I think a childhood of adversity taught me to be suspicious of the status quo. And then I read Thomas Kuhn's The Structure of Scientific Revolutions in college. It literally became my Bible. And so every situation, every paradigm I looked at, I was suspicious of, and I questioned and I challenged it. That served me well as a graduate student in getting my PhD, and it served me relatively well as a medical student, although the hierarchy of medicine expects you to be the obedient servant in residency. So I took all my background in neurobiology and went into radiology initially, and spent about a year and a half before I just couldn't stand it anymore and switched to psychiatry, and never regretted that switch. I think psychiatry allows me to really make a difference in the world and really help people, which has always been my goal. The neuroimaging came back, though, because I got involved in SPECT brain imaging, which is a functional brain scan that shows you what's working and what's not working in the brain. And in that role, I kept having to tell people, look, the scan shows you have a traumatic brain injury. We've got nothing to help you. Sorry, have a nice life. That was very frustrating to me as a clinician and as a person. So when the opportunity came to get involved in photobiomodulation, I leaped at the chance. But the very first thing I did was say, okay, we got to make this rigorously scientific. And that's how I arrived at this point of using photobiomodulation, that is infrared light, as a treatment for the brain, and thinking about all neurological and psychiatric disorders is really being about insufficient neuroplasticity and insufficient mitochondrial and neuronal health. That's probably enough.
Oh, yeah, no, I think that's a fantastic introduction. And it's so interesting because I think we're at an exciting time now in the field because of, as you say, many different multimodal kinds of approaches to management are almost by definition having to become more available for people, among other reasons, because legacy treatments, particularly medications, are just disappointing for so many people. Other kinds of options are sorely needed. Yeah, I'm curious. I think it's really interesting to hear, and perhaps we can spend quite a bit of time talking about those particular kinds of technologies and treatments that you've just referred to. But I was also interested in what you've written about and have content on in terms of depression and associated conditions like perhaps chronic fatigue syndrome as neuroinflammatory conditions. Perhaps maybe you could help us to understand your thoughts around that kind of thing as well.
Yeah, that's a really interesting story. Thank you for asking about that. That really, again, came from this work in neuroimaging. I had patients who were coming and saying they think they had a stroke. And a stroke looks very characteristic on a brain scan. The vascular territory of the involved artery is shut down. And I wasn't seeing that at all. In fact, what I was seeing was diffuse, patchy dysfunction throughout the entire brain. And that raises a question of, okay, this is something systemic. This isn't localized. This is involving the whole brain, in fact, probably the whole body. So that led me to ask the patients questions. And what came out was a downward trajectory of more and more fatigue and brain fog and concentration problems and memory problems and errors at work. And that very much sounded like chronic fatigue syndrome. Now, I had already had some brushes with the interaction of certain viruses, in particular Epstein-Barr virus, which is herpes 4, and herpes 6, which is just called herpes 6, in brain dysfunction, in areas of autism and things like that in my neuroimaging work. So as a clinician, then I started researching what was out there and discovered A. Martin Lerner's pioneering work on treating chronic fatigue syndrome with antivirals directed against those herpes viruses. So I started treating patients. And here's the weird thing. Not only did they recover from the fatigue and the brain fog, but their anxiety disorders went away. I started having patients who came in with saying, I'm depressed, doc. And okay, what makes you think you're depressed? I'm tired all the time. Oh, okay. So they had been diagnosed as depression and put on SSRIs when in fact they had a viral infection. So I started curing depression by treating them with an antiviral. So that sort of shift opened my eyes to not being stuck in a paradigm. If they say they're depressed or somebody's told them they're depressed, maybe you need to ask more questions. And the fascinating thing is I've now treated 400 or 500 patients for chronic fatigue syndrome, and all sorts of interesting things have happened. Their seizure disorders have gone away. That one always blows neurologists away. I have patients who were diagnosed with Parkinson's disease, and after treating them, their Parkinson's symptoms went away. And literally they go back to the neurologist, and the neurologist said, I guess you didn't have Parkinson's after all. So it's been remarkable to see the number of different disorders by symptom phenotype that turn out to actually be the results of viral infections. Alzheimer's, again, is a great example of this. We could spend an hour talking about Alzheimer's.
Yeah, absolutely. Yeah, in particular with some recent evidence that's really casting doubt on a lot of the underlying concepts around pathophysiology of Alzheimer's. But I think just the fact that you mentioned Kuhn's structure of scientific revolutions at the beginning is really interesting, because I think part of what many psychiatrists struggle with, particularly mid or later career psychiatrists, is working in the system and becoming frustrated with, and maybe having some more insight into the pharmaco-industrial regulatory kind of capture is part of what kind of guides training and then guides early practice. And you feel a bit like, because clinical practice guidelines are also part of, in a way, part of that capture. And then what your peers are doing is part of that capture. And you feel like if you want to maybe explore ideas that are out of the box, there's so many different barriers that get in the way of that. And the root of least resistance is just to go along to get along, and that ends up causing patients to be on 4 or 5 different psychotropic medications at the end of the day, because then they don't have, it's really sad in many cases, because they just don't have the opportunity to see someone like you who thinks out of the box and might diagnose them with more of an inflammatory condition that could in fact be curative, as you're describing.
Yes, it's very much that paradigm and the chemical imbalance theory that depression is about serotonin. That's been disproven. There are 4 meta-analyses, the latest was published about 2 years ago, that prove that serotonin has nothing to do with mood. The fact that Prozac increases serotonin, which it does in about an hour, is a happy accident. What Prozac really does as an antidepressant is very poorly, very weakly, if you're lucky, and Saturn happens to be in retrograde in Capricorn, that you will get an antidepressant benefit because it very weakly turns on neuroplasticity.
Yeah, that's interesting. And then you add in factors like placebo or expectation effects, and then those more recent comparison meta-analyses and RCTs are showing that often they don't separate out much from placebo effects. So there you go.
Yes, exactly.
Yeah. So maybe I'm interested then. So could you help us understand a bit about different technologies that people may not be familiar with that could potentially help with conditions like depression? In particular, I'm wondering about this infrared laser therapy, which sounds very interesting.
Yes. So the infrared photobiomodulation story goes back actually to the Soviet Union. So that's about 50 years ago. NASA played around with it for a little bit and found that they could speed the wound healing of astronauts. So the astronauts had an infrared device up on their vehicles, I guess is the best word. But Harvard and a few other places, Uniformed Services Hospital and the University of Sydney, really got invested in understanding photobiomodulation. So really key work came out of Harvard that showed that if you take 100 mice, whack them all in the head with a machine that gives them all the same traumatic brain injury, treat 50 with infrared light, those 50 that were treated get better. The lesion is smaller in the brain. There's evidence that BDNF, brain-derived neurotrophic factor, is turned on. This is the driver of neuroplasticity in the adult brain. And so there's evidence of increased synapses, increased dendrites, and those little mice that had a brain injury are up running around like nothing ever happened to them. So that pioneering work, and the same kind of work was done in stroke, showed that infrared light turns on a system, and that system involves first the mitochondria. So certain wavelengths of infrared light, if it can get through the scalp and skull and reach the brain cell, activates the mitochondria. I could go into all the science of that, but let's just leave it at that. The mitochondria in turn produce more energy, but they also send signals down to the chromosomes saying, turn on these genes. And so one of those genes is brain-derived neurotrophic factor, but there are several growth factors turned on depending on the cell type, as well as anti-inflammatory factors. So the infrared light is actually activating brain cell repair and neuroplasticity. Now, the problem is that the skull of a mouse is about the thickness of 6 sheets of paper. So a 1/2 watt LED can shine infrared light through that. We have much thicker skulls, mine thicker than most. And then our scalp is a good 6 millimeters thick. And a 1/2 watt LED doesn't even penetrate 1 millimeter through human skin. So an LED is not going to get through the scalp and the skull and get into the brain. That's the problem with all these LED devices that you can buy. You can go and spend $4,000, or you can spend $27 on Amazon and get an LED infrared light device that you can stick on your head and pretend that you're treating your brain. And I say pretend because it's not getting through the scalp and skull. Now, there is a skin effect. Something in the skin gets activated, which has benefit to the entire body. Treating the skin will speed wound healing throughout the body, helps the brain a little bit, but the problem is it's transient. If you don't keep doing those LED treatments every day, as soon as you stop, the benefit goes away. Now, contrast that with what we do. We went into the lab and figured out how to get through the scalp and skull and 3 centimeters into the brain safely and deliver the right amount of energy to those neurons to turn on the mitochondria. That took us about 1.5 years in the research lab, involving sheep heads, cadaver heads, living tissue, to sort out those penetration parameters. And we applied those parameters then to people. And we first were treating traumatic brain injury, so we had brain scans on them before and after treatment. And the changes were dramatic. And not only what you could see on the scan, but in these people's lives.
Right. Yeah, that's amazing. It's really, very interesting. And this idea about the neuroplasticity and the BDNF induced therapeutic changes, it's really interesting how there's a confluence that seems to be a unifying factor that's common to infrared laser therapy, the ketamine, as you say, to a small extent, SSRIs. Maybe can you help us understand, for example, like with ketamine then as another option to improve neuroplasticity and how that seems to really not only correlate, but cause improvements in conditions like the depression and chronic fatigue?
Yeah, great question. Thank you. So ketamine activates BDNF by a separate mechanism, and it does very powerfully. And through a series of molecular steps, it actually turns on both ketamine and the receptor for ketamine. So there's more stuff and more receptors for the stuff. So that boosts neuroplasticity. Now, one of the things that I recognized pretty early on was, what if we put the two together? infrared light turns on BDNF by a mitochondrial mechanism, and ketamine turns it on by a different mechanism through the NMDA receptor. And in fact, you get synergy. You get 1 + 1 = 3, not 2. And in fact, we patented that synergistic combination. And in doing that work, for example, I'll just give you one example. It's impossible to do the study where you treat someone with infrared light, you go back in time, you treat them with ketamine, you go back in time, and then you treat them with both and see which, you can't do that, right? Time machines only have one chair. The best analogy I can give you is that some of the patients that we treat with both ketamine and infrared light, their brain scans showed really robust improvement in brain function. Our depression patients who were severely depressed, and we combined ketamine with infrared light therapy. I had a psychiatrist call me up and said, "What the blankety blank did you do to this lady? She looks fantastic." So it's a very robust change. And there are other modalities that may have that same synergy.
Yeah, exactly. And I think before we started, you had mentioned neuromodulation techniques like transcranial magnetic stimulation. And so I guess that would be an example of some of those other technologies yet, I suppose, could continue to act even more synergistically. And it's interesting because it strikes me that what we're talking about really leads to a discussion as to how all of this is creating a sorely needed kind of environment where there's more of a personalized approach to improving mental health as opposed to the cookbook approach that is, like I said before, has disappointed so many people for so long.
That's a great point. Yeah, the neuroimaging work that I've done using functional brain scans or SPECT scans, it's been frustrating because, number one, psychiatry and neurologists just completely rejects SPECT scans. It's been a fight. And I actually wrote an article with Dan Pavel about 2 years ago called The Legacy of the Tassin Report. And the Tassin Report was neurology's initial assessment of SPECT scans 25 years ago, in which they said all these things are useless. But the SPECT scans of 25 years ago look like a Rorschach. They look like an ink blot. They didn't look like a brain scan. And now we have brain scans. I can see details. I can see the claustrum. I can see the putamen. I can see all the little brain structures I can see in a SPECT scan now with the quality scans that we have. And so you would think we'd be using those in psychiatry because it helps us to craft our treatment better. No, not at all.
Yeah. It's unfortunate. And I mean, I hate to sound conspiratorial, but when there's really hardly any other conclusions when you think about things like, why are there such a dearth of biomarker-driven diagnostics in psychiatry? Even something as traditional, or some might say outdated, as the dexamethasone suppression test. I remember mentors when I was in training who were very smart people who said that actually the DST is quite a reasonable biomarker diagnostic to add into the mix with any kind of clinical diagnosis of a major depressive episode, yet we don't use it. And I wonder if a lot of that is just because, again, that there's capture of the journals with the pharmacoeconomic complex, and the drug companies aren't really interested in having tests available that might rule out depression and decrease the number of people that might be candidates for the treatment.
Yeah, and bipolar 1 most often presents initially with a depressive episode. And the dexamethasone suppression test would differentiate bipolar 1 from major depressive disorder, from unipolar depression, and prevent maybe ever a manic episode, or you start treating the bipolar disorder appropriately. Same thing with brain SPECT scans. About 3 years ago, I published with colleagues in Mary McLean and a few others in Canada, a family who have bipolar disorder, and they all got brain SPECT scans, and their brains are identical, absolutely identical. They all have the same bipolar marker features of increased asymmetrical thalamic activity and asymmetrical increased cortical activity. If we did a SPECT scan on unipolar depression, then yeah, we would pick up those bipolar cases before they became severely manic. And the savings in the economics just for the patient, not losing their job with a manic episode having a worse course because they were put on an antidepressant initially. All of those things could be prevented if we use biomarkers. Yeah.
Yeah. And SPECT is relatively available, even up here in Canada, where we have our default. I'm a little bit embarrassed to say our default for neuroimaging on the geriatric side, where I'm spending most of my time, is still cranial CT scanning. So even in our environment, SPECT is relatively available. And again, in geriatric population, to help differentiate certain kinds of dementias, it can be obviously quite helpful. But we don't really think, I don't have a large younger or middle-aged adult practice, but I think with colleagues, I don't, any of them would ever think about ordering a SPECT scan, but I can see why there would be a lot of value in that on the diagnostic side for sure.
Yeah. Yeah. And we could talk about Alzheimer's and the Alzheimer's imaging, and where SPECT is more valuable than, say, even a amyloid scan. So again, you're right. That's this engine that drives things, and nuclear medicine and radiologists want to do amyloid scans.
Yeah. Yeah. It's interesting. And I think, even more interesting because of all the recent concern that's coming out regarding the potential that the whole amyloid hypothesis for Alzheimer's might be somewhat or perhaps completely off the mark. And so what does that mean for the whole approach? It's really interesting. How about the long COVID syndrome? Everyone is still concerned about the legacy of COVID, obviously a huge, very impactful time for everyone, very disruptive for all kinds of reasons. And many folks are left with this long COVID. So I really don't know too much about it, but it strikes me as interesting in terms of the potential overlap with something like chronic fatigue syndrome and the neuroinflammatory component. Do you mind helping us to understand a little bit more about your work with long COVID patients and how that ties in with what we've been talking about?
Yeah, I'd be happy to. I just gave a presentation at the World Brain Mapping Conference in Los Angeles a few months ago. And so this is fresh in my head. But the estimates are that about 30% of people who got COVID will develop long COVID symptoms. And long COVID symptoms are fatigue, brain fog, memory problems, sometimes neurological symptoms like tics or tremors, and also gastrointestinal symptoms. And then a lot of patients will have persistent pulmonary symptoms, shortness of breath, et cetera. The theories about COVID, long COVID, are that number one, maybe there's fragments of the spike protein left over floating around in the brain or the lungs. Another theory is that there are micro clots throughout the tissues. I think that is less likely. But the most prominent theories and the strongest theories are, number one, that there's persistent inflammation in the tissues. In fact, I've had 3 of my own psychiatry patients who went to the local pulmonary hospital and had lung biopsies because of their shortness of breath and chest pain. And they were told, oh, we found inflammation. We don't know what it is and we don't know what to do about it. But that's how big inflammation is a part of this. So inflammation in the brain as well. The second prominent theory is that long COVID, because of the cytokine storm, induces a reactivation of latent infections, such as Epstein-Barr or herpes 6. Now, not everybody has Epstein-Barr or herpes 6, despite medicine's claim that's the case. It's really in my hands. It's about 60% of patients that I have tested have Epstein-Barr, and about 55 to 58% have herpes 6. The third theory is there's reactivation of latent bacterial infections, such as Lyme disease, Bartonella. So in treating these patients, number one, I always go looking for the Epstein-Barr evidence. And if that's there, I'm treating them with antivirals. But we're typically treating the patients with infrared light. And around about treatment 10, their fatigue begins to improve. And around about 14, 15, their cognitive function is back to baseline. I'll give you just one example. So a dentist came up from Florida, and he had been sidelined by the fatigue and the brain fog, and he had developed a tremor. Not good for a dentist to have a tremor. And he had tried everything. He had tried hyperbarics, he had tried various infusions, he had tried ozone therapy. So he came to us pretty desperate and having spent a ton of money on all these other failed therapies. He had 20 treatments. Roundabout treatment 14, he pulls me aside and says, "Doc, this is weird. I've taken Vyvanse, a stimulant, my whole life because I have ADHD. And now it makes me jittery. So I stopped taking it. And doc, I can concentrate just fine. And so he not only did his fatigue go away, his mental clarity came back, his energy was through the roof. He was doing fantastic. His tremor gone, and he no longer had ADHD. And so he stopped taking his Vyvanse. He stopped needing to take Xanax at night because it was so much less anxious. And he went back and he's working, but it's now 2.5, 3 years out. I communicate with him every 6 months. He continues to do fantastic and he doesn't need a stimulant.
Yeah, that's fantastic. That must be so rewarding to be able to help folks like that who just had so much frustration with other options.
That is one of my core values is I want to bring hope to patients. They're told all the time, oh, there's nothing you can do about it. And that frustrates me.
Yeah. I think I'm wondering just in terms of what any clinicians who are listening might be able to start doing in their daily practice to start thinking more about this and incorporating some of these ideas. Are there some basic blood tests? I guess it's difficult to say specifically, but in general, is there a basic approach to the workup or becoming more suspicious about a neuroinflammatory kind of contribution to mental illness?
Yeah, there is. And I'm happy to share it. And in fact, if there's a clinician out there who wants help with getting started doing this treatment, because I don't own this is Dr. Lerner's work. I'm just championing it. So I'm happy to be a consultant for people who need that. So basically, I look at antibody titers for the herpes viruses. So I check herpes 1, 2, just because I like that metric, and herpes 1 is important in Alzheimer's. Herpes 3 is varicella, and that's, again, it's a good kind of landmark because most people have had varicella and therefore they'll have antibodies. And what you'll find is their antibody levels are really low. You know, if they have active Epstein-Barr virus, their antibody levels will be very high. So for Epstein-Barr, there's a viral coat antigen and there's a nuclear antigen. And then there's also what's called the early antigen. And that's the piece of the protein coat that goes in and takes over the DNA machinery. So it's important to look at that. I check herpes 5 because I see that as a very small fragment of my chronic fatigue patients, so cytomegalovirus, and then herpes 6. The rest, they get more expensive because they're uncommon. So 7 and 8 are genetic variants of herpes 6, and 9, 10, 11, 12 are only known from brain biopsies. So I often offer my patients, hey, I'm happy to go get my drill. They generally turn me down. As the rest of the lab workup, a CBC, and then you do a lymphocyte subset profile that allows you to look at the natural killer cells and CD4 and CD8 cells. If they can afford it, a cytokine panel, but generally they cannot. So then just do a TGF beta. It's much less expensive and it's the best marker right now for chronic fatigue syndrome and pretty good for long COVID. I also do a C-reactive protein. And then I check a creatinine and a liver function because I'm going to be putting them on an antiviral, which rarely, and let me emphasize, rarely, like twice in my career, has anybody had any kind of liver problems from the antivirals that I'm using.
Yeah, no, that's fantastic. Really appreciate that. And just for viewers and listeners, I'm going to put links to Dr. Henderson's content and contact information in his clinic and the book as well in the show notes. So I really encourage people to check that out. Maybe just since I referred to your book right there, maybe you can tell us a little bit about that and the story behind the book and what you're hoping to accomplish by writing that.
And the book evolved as I wrote it. You rewrite books like 5 or 6 times. And what it came to be was my attempt to help people rethink depression. And so I used ketamine as a model, but it's not just about ketamine. But I think the way that ketamine is administered, at least in the US, is backwards. The standard protocol is 6 infusions in 2 weeks. And where that protocol came from, so it basically came from the early studies. And I actually asked one of the investigators in one of the early studies why they did 6 infusions in 2 weeks. And his response was quite literally, I don't know, it sounded good. That's the science. So there is no justification for it. In fact, there's a counter justification for doing 6 infusions in 2 weeks, and that is neuroplasticity. You're not going to make neuroplasticity happen any faster by having somebody get an infusion every other day. In fact, in my clinic, I never do infusions more than once a week. And now most of the time it's every 2 weeks. And so by giving neuroplasticity time to work, my patients get better with 4 infusions. So and my response rate is a 78% response rate. And the national average is 51, 52. So by giving time, people spend less money, get less ketamine, and have a better outcome. I kept telling that story, and I kept telling horror stories of how other ketamine clinics had given people giant doses and then left them in the hallway. And I said, I need to just write the book because I keep saying the same thing to people. And so that was where the book originally came from, is I kept finding myself explaining the same thing over and over. But I think the book, most importantly, the book gives hope. There's lots of stories of patients and even patients who failed to get better with ketamine. And that's what leads me to help people understand there's more to depression than just chemical imbalance.
Yeah, fantastic. Yeah, I really appreciate that. I appreciate the message of hope because it is, we've been saying a few times today already, that historically there's just such a frustration, I think, with clinicians and patients. Patients are often left feeling hopeless because after years, maybe even decades of ineffective or partially effective treatments, they still have suffering, they still have functional impairments. So hopefully with all these other kinds of options, and people can continue to just try to maintain hope that they'll find something, some combination of treatments that ends up working better for them.
Mm-hmm. Yep, exactly.
So yeah, based on that and your experience with all these innovative therapies, what would you say is perhaps one of the biggest or a couple of the biggest potential opportunities for improvements and positive changes in mental health care over the next 5 to 10 years?
Certainly one is the adoption of infrared photobiomodulation, particularly if they're using a multi-watt protocol, such as what we do. I think that would revolutionize brain health across the spectrum. One of the things we haven't talked about is certain wavelengths of infrared light actually speed the clearance of toxins from the brain. So you want less amyloid in your brain? You want less alcohol-induced toxins in your brain? You want less age-related toxins in your brain? Infrared light. The other is this revolution that's happening. The next generation of transcranial magnetic stimulation devices have emerged. And these devices have much more powerful magnets. They're close to literally an MRI in terms of their magnetic field. And it, number one, speeds the treatment. So treatment is reduced from 40-hour-long treatments every day of the week down to 6 treatments lasting 20 some odd minutes. So that revolution, TMS, interestingly, TMS turns on neuroplasticity and activates BDNF by yet a third mechanism. So what we're exploring now in the clinic, and I'm super excited about, is the synergy that could occur between infrared light and transcranial magnetic stimulation in particular areas of the brain.
Yeah, that's amazing. So it's really interesting to think about why all these synergistic therapeutic options start to add up. Exactly as you're saying, you combine that perhaps even with ketamine and then just even the positive therapeutic relationship. And that's, in some ways, it's really not surprising that you're getting such excellent results. So congratulations for that.
Thank you. Thank you.
Yeah, that's great. So I guess I'm curious, because you have mentioned some of your research endeavors, what would be some future ideas or some hopes, plans for collaboration or research projects over the next few years?
Great question. Very timely too. I've had a long relationship with Harvard, and we're a group of scientists there under Paulo Cassano and I are working on a grant. And this is looking at comparing the low power infrared light, the LEDs that you can buy and stick on your head at home, versus the multi-watt protocol with controls. And the grant that we're preparing to submit is going to the VA. So it'd be looking at traumatic brain injury in veterans. And the veteran population is so important and underappreciated, at least in the US. And every day, the same number of veterans die by suicide in 2025 as was true in 2017. No progress has been made for them. And so when I look at the power of ketamine, the power of multi-watt infrared light, and the power of these next generation transcranial magnetic stimulation devices, such as the ExoMind, to help, it's just mind-boggling to me why we're not treating veterans aggressively with these type of modalities rather than pills and group therapy.
Yeah, particularly the traumatic brain injury or the PTSD kinds of issues that are so common in veterans. Yeah.
Yeah, exactly. Yeah.
For sure. I really appreciate it. Before we wrap up, is there anything else that you wanted to bring up, Dr. Henderson?
And the only thing I would say is that I've got one clinic in Denver. This should be all over the country. So if any listeners out there are interested in investing in the next generation in healthcare, give me a ring and I'm happy to talk about it. A research study such as looking at PTSD or looking at Parkinson's or looking at Alzheimer's costs about $3-4 million. And the grants are difficult to get because we're not a university. And moving the field forward is a slow, laborious process. The potential for helping people across North America, I'd be happy to have a clinic in Canada. And we've explored that with my colleagues. It will also take capital.
Yeah, definitely. Kudos for all your efforts. And again, it's so exciting and heartwarming to hear about all the folks that you're helping. So thanks again for a great discussion. And,
Absolutely.
I just wish you all the best. And maybe we can have a coffee sometime at an upcoming conference.
That'd be great. Excellent.
Okay, that's great. So that was our conversation with Dr. Theodore Henderson, who's pushing the boundaries of what's possible in psychiatry and mental health care with evidence and empathy. If you're curious about treatment options like infrared laser, if you're curious about how neuroinflammation is implicated in various disorders like depression, chronic fatigue, long COVID, or if you're curious about how the future of mental health treatment may well involve light instead of just pills, his work is really essential reading. And I'd encourage all viewers and listeners to check out his book, Brighter Days Ahead. Again, I'm going to put links to where you can find Dr. Henderson's content in the show notes. Once again, Dr. Henderson, thanks so much for joining us and just wish you all the best.
Thank you so much for having me. My pleasure.
Okay. Have a great day. See you later.
Thank you. Bye-bye.
Bye.